Dr. Rajiv? Yeah. Dr. Rajiv, now just now we have entered the scope inside and we are seeing what is there. There is a, this is the ACL which is seen over here. You can see. This is a ACL floppy sign what I feel like, and PCL injury is there. Now what we are looking after is the medial meniscus. Medial meniscus is fairly good but shattered, and now we are going in the lateral compartment. How we will come to know whether they are listening to me or not? Is not there, but still they are listening, na? So, okay. Now I am in the lateral compartment, and if in lateral compartment, if you will see, this is the meniscus which is over here, and the popliteus tendon, you can see it here. And now my plan here is PCL reconstruction plus PLC posterolateral corner, because the history wise, if you will see, and the clinical examination is showing that recurvatum test as well as the posterior posterolateral rotation test is positive in this patient. And there is a posterior drawer which is positive, and now what we are trying to find out is a diagnostic round. We have made our portal, and now what I am trying to find out, just probe please, probe please, probe please, probe please. MRI has shown a partial ACL tear with all the posterolateral component involved into it. Now I am just finding out whether ACL is there kya. If you will see, even ACL is not in such a good manner. Over here if you will see, it's just, so at present this PCL, this ACL floppy sign is also present, as well as if you will see, there is a PCL component which is involved. Now what I am planning is, in this case if you will see and ask me, this is the lateral compartment which is opening, which is almost more than 15 mm. You can see it here easily. And now here, as ACL is intact, lateral meniscus is intact, medial meniscus is okay, and PCL insufficiency is seen over here, if you can see. So my plan is to go ahead and do a PCL as well as a Is this working?
Change the mode one.
Now if you'll see, I am just debriding some of the fat pad over here, and while debriding the fat pad, I will be entering through the two windows for the PCL, that is, I will be entering it. Today my aim is to show you a posterolateral bundle corner reconstruction, which I am doing it with the help of the semi-T, which I have harvested already. And for PCL I will be doing double bundle PCL reconstruction, for which I will be using a peroneus from one side and the semi-T from other side, and one semi-T I am using it for the sake of the posterolateral corner. I am going to demonstrate a modified Larson's. So this fat pad which is coming in my way, I am just debriding it out at present. पकड़ जरा, इकडे या ना एक जण, इकडे या. So here if you'll see, water please. सर ये कैसे करना है?
So this is for mode, and then you can see. So now let's press the second button.
So as we are going for the posterolateral corner, I am going through the window between the ACL and the PCL. This is the window which I am creating it between the ACL and PCL. Here ACL also partial tear is there. Once if I remove this, if you will see, I have entered inside and I will be going towards the posteromedial compartment. This is the part where I am entering inside the posteromedial compartment. I will be entering just, this is the septum which is present here, which I am trying to shave it off. This is the second window which I am using it. First window is in between the PCL and the medial femoral condyle. Hold it please. Yeah. Now if you will see, I have entered inside and this is my septum. You can see this. This is the septum which I am just trying to debride it and enter for my posteromedial compartment. So both I will be doing it here today. No, I will be doing PLC tunnels first, PLC I will complete it and then PCL I will be doing it afterwards. So because when we are doing the PLC with PCL, always I prefer to do a fibular tunnel first, complete my job over there and then enter for the PCL. So I will be completing the PCL. That means what I mean to say, I just want to do fibular tunnel, as well as the femoral tunnels. I will be completing the PLC, but I will not be fixing the PLC. I will be fixing the last screw of the PLC in the end. That is for the lateral collateral ligament which I am fixing. That I will be doing it in the end, because I will be fixing the PCL first. That is double bundle PCL what I am doing now. In this case will be so my plan here is to create a space for the posteromedial portal, and as such I have done it now. So this is the first window which I have created. You can increase the so for PCL again double bundle I will be doing a remnant preserving double bundle. That is, I won't be removing the remnants in case of PCL also. Double bundle remnant preserving PCL as well as the PLC. So today I will be showing you this case. If you see, so Rajiv, I know that you are also doing very good numbers of PLCs. So modified license today plan is there. If plus injury was there, like Popliteus would have been completely smashed, and what Laprade used to say like grade 3 plus, then in such cases I would have done Laprade. That is, even we have started doing now arthroscopic Laprade. That is, I am doing it, but arthroscopic Laprade just at present we have done only 7 cases. Yes, and modified license we have published our technique, but today let's see how it goes usually. So here, because of this multi injuries, you can see here lots of fibrous tissue is present in the posterior compartment, and even I am not able to reach to the posterior compartment till now. Here if you see, there is full of the fibrous tissue which is present here. Now I have managed to enter the posteromedial compartment, and now I will be doing the needle please. I will be doing the 2 portals for this. That is, you can see here I have made a low posteromedial as well as a high medial portals, 2 posteromedial portals I will be doing today. This is the posteromedial portal which I am trying to create. Just bagun theva zara. Here this is the soft spot which is present, and I am coming in between, and I am creating a posteromedial, low posteromedial portal, what I said. Hold it, bus. This is for a low posteromedial, 1 minute, 1 sec. This is for the low posteromedial portal, and now I will be making a high posteromedial portal. You can see this is the high posteromedial portal which I want. Thank you, Akshay. Here today Akshay is there with me. And this I am creating a high posteromedial portal through which this will be my weaving portal for some time, and after that I might switch to the low posteromedial portal as well. That depends on the case to case. Yes, when I am going in the posterior compartment, it's very difficult, especially when I am going in the posterolateral compartment. Put it. Now I am putting a cannula for the posteromedial, low posteromedial portal. This is the cannula which I am placing it. Hold it. Some skin incision is needed. So we have placed the cannula in the lower space, and now I will be debriding. Just give me proper. So as I shown you, this is my first window and this is my second window which I will be showing you in a meanwhile. This is my window which I am coming it from this portal. But today, believe me, this is not a case for the demonstration, because here you are having a PCL, MCL, PLC, all components, and you can see all the fibrous tissue and the bands which are looking in front of me. It's really scary to see, because to operate for a posterolateral corner, you need to at least visualize all the things. Now I am trying to remove the septum which is present here. Yes. So now I am using a posteromedial portal. Hold it. You can see I am just posterior to the PCL. Here I can't differentiate where is PCL, where is PLC, because if you'll see, it's full of fibrous tissue present posteriorly. So slowly I will be releasing all the things. Let's see how it goes. रुक भाई, रुक 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 रुक. So this mode is troubling us. So now I will be removing this septum which is present here in between and trying to go ahead. Hold it. Usually we won't get this much fibrous tissue. So it's really a challenging case to go posteromedially to posterolaterally and to create a tunnel for the fibula as well as for